We are very excited to welcome you to this special Rigam Vet webinar. And we'll be talking about new innovative approach for treating periodontal disease in pets. Something we know that is a daily challenge in many veterinary practice. So I want to say a few words about BioChange. This is a biotech company focusing in regenerative medicine. Our mission is to help the body heal itself using advanced tissue repair technologies. And that's exactly what Rigam Vet is doing, supporting natural healing of the bone and soft tissue. And before I will introduce Dr. Jennifer Mattis, I have with me Dr. Iris Shichor, the CEO of our company. Hi, everyone. And we are very lucky to have Dr. Jennifer Mattis for the second time. She brings a lot of experience, but also passion for improving pet care through innovation. Dr. Mattis is a board-certified veterinary dentist from Des Moines, Iowa. It was challenging.
You said it right. I'm shocked.
And she has more than 20 years experience in general practice. She has also become a certified veterinary pain practitioner and medical acupuncture through the International Veterinary Academy of Pain. Last year, she was honored to be the best speaker of the year in a WVC hands-on laboratory conference among 375 national speakers, and it was an event with 30,000 attendees. We hope that this session will give you valuable insights that you can bring to your practice. I give you the opportunity to start. Thank you, Dr. Jennifer.
Okay, so we can get right into it, right?
Right, so let's start.
Okay, so let me share my screen. And so I have these from before talking about BioChange and how they're trying to facilitate tissue regeneration. So that's cool. We'll talk about that more and how we use it. I want you to look at this first image, this embryonic structure, basically. And it's kind of a foam structure, and Regum is trying to replicate that to try and facilitate with regeneration. And it's so synchronizing and communicating with the cell growth. And so you've already talked to them. Make sure you communicate with Hillet and these people for more information after today's webinar, but I just wanted you to have that. Would you provide your information at the end of this, Hillet?
No, this is great what you did. Now they have my
so
email.
basically, you need to communicate, make sure you screenshot this or something like that. So, okay, so we're going to get into it. The goal of this is saving more teeth. And so we just, this is in practice. When we find something, we need to be able to treat that properly. And so I would encourage you to have Regum on hand, and so you can treat that when you need to do so. In the middle of this picture is my mentor, Dr. Heidi Lowprize. I'm one of the monkeys in her circus. In other words, we like to have a lot of fun. We're being goofballs here, but we do get a lot of other things done. These are Dr. Lowprize's textbooks. Anyway, you already learned I was a continuing educator of the year. Again, we also get things done. I have papers on pain management and papers on periodontal therapies. And it's already actually on Amazon on Kindle right now, but it will be available in print in June. The Senior Animal Care, I have a textbook on chapter on pain management in there. And there's other upcoming things in the 8th edition of the 5-Minute Veterinary Consult. So when we talk about dental issues, it's likely to be present in 3 out of every 4 pets. And those are the Frustrati studies done in 1998, and they still hold true to today. So these radiographic studies show that 72% of dogs and 86% of cats have essential or additional findings beyond their exams. So if you flip the lip, there's actually probably more going on. So the first thing we need to do is image and figure out what's going on, because dental disease is the most common and most underdiagnosed disease because it's all hiding underneath underneath the gum line, it's going to be undervalued and underdiagnosed unless you do intraoral x-rays under anesthesia. And when we associate things, it's been known that dental issues relate to other diseases in the body. In fact, other diseases get better when you keep the mouth healthy as well. So this is not the slide, but it talks about, not in here, but there's studies about diabetes, insulin resistance improving. And when you keep the mouth healthy, there's studies on patients with heart disease having a better status quo, patients with renal values having better renal values when you keep that mouth healthy. So in 2019, there was a 2 million dog study, and those that had annual anesthetic dental procedures lived 20% longer. And it doesn't appear that anesthesia is cumulative in that way. It's hard to say. And there's a 2018 study that compared patients that had non-anesthetic dentistry to those that had no dental procedures, and those that had non-anesthetic dentistry were worse than those that had no dental procedures. So it is important to do this and do this every year. So periodontal disease is 5 times more likely to be present in pets than in people. We measure periodontal disease by bone loss around the teeth. And since we need x-rays to see the bone loss, you can't know that awake. And so when your client comes in and says, hey, what's going on? You're going to obviously undervalue it unless you have a tool. One tool that's available is AuraStrip DX. And it's been shown that when you use this test, that you can look for this color change. That's the next slide, actually. But the studies using this test showed that dogs aged 1 to 2, 53% already had bone loss. And by the time they were age 3, it was 84 to 87%. And in a different study and done in 2014, they just evaluated a bunch of 20-pound dogs, only age 1 to 7, and none of these owners wanted to do home care. And so they came in and they cleaned their teeth, they got a nice clean slate, and then since they wouldn't want to do home care, they wanted to evaluate how things were happening. And they came back and assessed them every 6 weeks, and as soon as they found bone loss, they were out of the study. All but one dog was out of the study within 66 weeks, and it happened 5.5 weeks sooner for every year older they were. So this is happening, and it's happening fast, and it's happening hidden. And so we need to look for it, because this is a tool that you can do to an awake patient where you take this little strip. It looks like one of those urine dipsticks, only it's one little pad, and it's looking for the presence of bacterial thiols. So when you have plaque, that fuzzy feeling when you wake up in the morning, it's hiding in the gingival sulcus, the space between the gum and the tooth, and it is changing from a normal biofilm to a different change in biofilm, and the types of bacteria inhabiting that change over time. And as that changes, the thiol producing bacteria become more prevalent. And when they become more prevalent, there's associations known that when you see the bacterial thiols, there's association with bone loss. And they found that when you had basically a 3 right in the middle, or basically any yellow, there's somewhere between a 53 and 100% chance of bone loss. And so you need to, that's one tool you can do. It's just a 10 seconds test where you look at the color and see if there's some color there, and that would say there's a 53+% chance of bone loss in that patient. Because when we look at the patients, like we look at this picture here, we're just looking at tartar. This is a guess on what the stage it is. We really don't know. Stage refers to the amount of attachment loss. So we should probably call it level until we know what's going on, because this is just a guess. This is not correct. This is correct, where we can say stage 1, where there is no bone loss. Stage 2, where there's 1% up to 24% bone loss. Stage 3, it looks like there's hardly anything. That stage 3 one would be perfect for Regum Vet, where there's 25 to 50% bone loss. Now, I've seen way worse stage 3s, but this is where there is just a little more than half of bone loss on one part of at least one root to make it a stage 3, and then stage 4 is greater than 50% bone loss. And so we can save this stage 3, and the stage 4 one, it's going to be saved in a jar. because there's no bone left around the tip of the root. Once the apex is involved, you have to say goodbye. So it's not just x-rays, they're really important, but we also need to evaluate each tooth periodontally, which means we need to have a complete exam. We need to probe around them very tactile and gently and evaluate those pocket depths. Those pocket depths is when we're going to find an issue and we're going to see the depth and decide how to treat that and then use regum for that. And so when we evaluate pocket depth, it's not just the depth alone, it is the pocket depth, but it's also any root exposure or that makes the attachment loss. In other words, if there's gingival recession, there's actually more attachment loss. And so if we measure this 1, 2, 3, 4, 5, 6 millimeter pocket depth and 1, 2, like 3 millimeters of root exposure, the total attachment loss on this particular image is 9 millimeters, even though your pocket depth is only 6 millimeters. And if they have excessive gingiva, you might think that there is a deeper pocket when it's not truly attachment loss. So there's quite a variation. If we look at the one on the right, that one has excessive gingiva. Its pocket measures 12, but 4 millimeters of it is gingiva excess. So it's really an 8 millimeter periodontal pocket around the tooth, but that 8 millimeters already goes to the tip of the apex of that tiny premolar, and that tooth needs to go bye-bye. Whereas this one already has some gingival recession, but the pocket depth is only 1 millimeter, and so it's not a problem on the left of your screen. So when we talk about treatment of teeth, we have to talk about minimizing attachment loss. We want to minimize our pocket depth because the presence or the absence of periodontal pockets is the greatest predictor of gingival health. And we want to keep that gum tissue there, that gingiva. If we lose the gingiva, we can't support healing. So what is this thing, this plaque, this biofilm? It forms on any wet surface. You can't just throw antibiotics at it. Antibiotics, biofilms are 10,000 or 1,000 times more resistant to antibiotics. Technically, we can sterilize it with our ultrasonic cleaning until it recolonizes. It begins reforming in a couple seconds, but it actually has a reformed, a normal, healthy biofilm within 2 minutes. And as I alluded to before, as the bacterial types change over time, you can get that thiol producing bacteria, which will cause bone loss. But the only people that are working, if you brush the teeth, you're really not working sufficiently in the sulcus unless you're really getting in there. But most pets won't allow for that. And the ones that are effectively doing it in a pocket is the veterinary team. So we are the ones that's doing the treatment that's going to make a big difference in that patient's life. We're talking about this little space right there between in that circle, that blue circle with that little pink area between the gum and the tooth. So this is a hidden disease. And again, it's a repeated association between the inflammatory process of the mouth to other diseases in the body. And so that's why we need to do our complete anesthetic dental procedures to make sure we treat it appropriately in the gingival sulcus. So stage 1, as we talked about bone loss, this is no attachment loss. It may have an increased sulcus depth because it's still in the 1 to 3 millimeter, but it actually hasn't lost attachment. Sometimes you get some edema to the margin of the gingiva. But the edema is reversible. And so once you clean it, everything returns to normal and you're back to normal, stage 1, which would be great. Stage 2, this is the up to 25% attachment loss. So we want to see the junction epithelium to the base of the sulcus. So there's the periodontal ligament, that's that black line surrounding the tooth. You need to evaluate it. To evaluate the gingiva, and you need to evaluate that mucogingival junction. This here, this line, the mucogingival junction or mucogingival line. My concern with this patient is that it might have a pocket depth of 1 to 2 millimeters, but it's already had some attachment loss right here and root exposure. And if we just allow that to continue, once you get past this MGJ, so basically we just have to watch that. The good news about this one is technically we could do appropriate cleaning to clean this one up. And all we need is a good cleaning underneath the gum line. Well, some people don't know what cleaning is. I want to talk about that in a minute. So we talked about most of these situations are treatable. They may have some root exposure. But if you have pocket depths up to 5 millimeters, then we can go ahead and clean that. Now, I mentioned 5 millimeters. That's an important measurement because our tools can't clean properly beyond that. The other thing is we have to consider our tooth root size. And so a tooth root that is like an incisor that maybe only is 5 millimeters in length, a 5 millimeter pocket depth on an incisor is way over 50% bone loss, and that was the one we should say bye to. Whereas a 5 millimeter pocket on a canine is probably way less than 24% bone loss. And so we would just treat that with cleaning properly. So I want you to write this down, tooth.vet/regumvet. I haven't built that out yet very much, but there is a video located there. And so the next few minutes, I'm going to talk about how to clean. If you want to review how to clean, because most people raise their hand and say they thought they knew what a curette was, but they're not 100% sure. And they don't really know how to use hand instruments. And that's something we need to figure out to be able to clean that pocket appropriately. And so on this picture, we have a curette on I will highlight it here. This is a curette and this is a scaler. And so a scaler, sharp S, this is for above the gum line. This pokey thing, we don't want to poke below. This rounded toe, this is a curette. This happens to be a Gracie curette. There's a couple different types. They also make ultrasonic Gracies. This is called an H3. It's an ultrasonic Gracie. So scaler, sharp tip. These have two cutting surfaces, and these are for above the gum line. And then there's two main types of curettes. There's a universal and a Gracie. So the universal, because you can use either side, and so it's universal. But when you place a universal in the pocket here and place that down, you actually have to turn that face. And I have a hard time getting that into the right angle to engage the tooth surface to be able to clean it properly. And so I'm not a fan of universals because I have a hard time in making that turn like this before I pull up and clean that up. Whereas a Gracie already has that angle. So when you place it in, as long as your terminal shank is parallel to your root, then it's already at the right angle and you place that in and pull that up. And that's how we clean that area appropriately. But these are only effective for 5 millimeters unless you open the pocket or open it up to get lower than that. They do make universal Gracies, which are on both sides. They're just pretty rare. IM3 has them, LM Arta out of, I can't remember where it is in Europe. I forgot. Anyway, so they are available for you guys. Aesthesia Sweden also has these. So when you place that in there and then you pull that up. And so back to the difference in stages, stage 2 was typically cleaning. Stage 3 is up to 50% attachment loss. We have to, these are the ones we're really going to need to treat, but we have to decide on the tooth. If it's an incisor tooth, is it worth saving? If owners really want it, maybe, but I'm not sure it's really worthwhile. We want to decide on the patient, and we have to think about the owner because a lot of these need owners to come back and be compliant with home care and come back and return for procedures. By the time we find them in their severe stage 4, we usually have to say goodbye to them because there's mobility, or there's exposure to the tooth, there's insufficient gingiva. These have to go by Regum's not going to save that. So the exceptions exist. We have to have the right conditions. And that's when you find those conditions, that's where you need to have Regum on hand. If you wouldn't want to wait to order it, you should just have it there with you so you're ready to use that. And so here is a case. This is called horizontal bone loss. There is insufficient gingiva. It's being held in by calculus splint. We should say goodbye to this area. Now, we need to make sure we take x-rays of the entire mouth because this is the opposite side. We want to make sure that we didn't break this jaw. It was already broken before it came in. But look at all of your areas first. This is an area where it'd be contraindicated. Even though the tooth looks fine, the cyst that's happening below has damaged all the tips of the roots, and we have to say goodbye to those teeth. Regum would not fix that. But this is an example of some horizontal bone loss. Now, just based on periodontal disease stage and bone loss along one root, technically it would normally be a periodontal disease stage 2 or maybe a 3. Let's do some math on that. Here to here, so this is 50%. So it's borderline between 2 and 3. But the special thing about this furcation is that through and through furcation is an FE3. You add 1 to the furcation number, and that gives you the periodontal disease stage 4 that you want to think about for treatment. So when it's a periodontal disease stage 4, can we save it or can we not? This particular one, because we were able to move this gingiva down and see the furcation exposure, in other words, it still covers it, this one would probably be an excellent candidate for regum, as long as the lingual gingiva is appropriate. If it does not have gingiva to cover it, it won't work. Other people say, well, let's just move it because this acts like a one-way valve, and let's not have that one-way valve because things like can get stuck up underneath there. This particular patient was present before regum was available, and it was my colleague's patient, and she was talking to the owner about what she found underneath there, and she said, I found carrots underneath there, and the client said, I haven't fed carrots for over 6 months. So these things are happening and they're changing without us knowing. So we need to look for these things. This is a similar case, but instead of being through and through, this is a furcation exposure 2, which makes it periodontal disease stage 3. And you can see how 3 months later with the use of regum, it has worked excellent. This is another situation where this is periodontal disease stage 4. So there was sufficient gingiva. This is a little bit harder. This is not always going to work, but it's definitely something that regum can be used for. Regum was used to bring bone back to this site a year later because there was sufficient gingiva and all the disease was cleaned out from those sites. Now, if there was insufficient gingiva, it would not have worked. So let's look about these examples. What's this one? We talked about little differences in bone, and there's not horizontal bone loss. There is some vertical bone loss there. These are also ideal candidates for regum vet. Which periodontal disease stage is this? So we look at that and we have here to here is 100%, this is 50%. So this is greater than 50%, which means this is periodontal disease stage 4. But this is one of these perfect situations for using regum vet, or you could use guided tissue regeneration, which is similar. But this pocket depth was greater than 5 millimeters. We needed to remove this unimportant tooth, the one that was here, because in the previous slide, it looked like they were like this, but this area always has overlapping teeth. So the x-ray makes it look, I don't know if you can see me, like they're butted up, but they're actually overlapping. So to get to that place, to clean that out properly, we had to take out 408 to save 409. And 409 is your important chewing tooth. That's the one we want to save. And then we can place, once it's been cleaned properly, we can place regum vet in here. And then make sure that gingival collar comes over that. And this is what it looks like 6 months later. And we can never return it to PD1 because that's no bone loss. You will always have at least 1% bone loss. But we can make it healthy without a pocket. And this is a periodontal disease stage 2, but healthy tooth. Traditional guided tissue regeneration or standard guided tissue regeneration is the formation of new bone through the use of a membrane. And historically, bone grafts are unlikely to have success without a graft or a membrane because epithelial cells migrate 10 times faster than any other cells. The difference with regum vet, remember that first slide, we talked about that foam structure briefly? That is going to be a communication structure. And so if your epithelial cells want to migrate, they're going to migrate on that framework. And that's what regum is. And so it's going to function as a framework. And so it will prevent that epithelial downgrowth. Historically, types of barrier materials are things like doxyrobe, which is can be messy to deal with. And that's normally found in the US. It's hard to be found elsewhere. Ossiflex is really hard to manipulate. This regum vet is much faster to handle. And the other ones would have to have an actual graft material, which costs more money as well. And so regum vet is the best choice because it's not truly a barrier, but it provides a framework for cells, so it doesn't allow for the soft tissue downgrowth. I need some soda. Anyway, graft materials. There's all sorts of different kinds of graft materials. You can classify them by osteoconductive, osteoinductive, osteogenic, and which ones they are. Conductive is basically a scaffold. And there's also osteopromotive, which is also formation of new bone. And then there's osteoconductive, which is also a scaffold. Osteoinductive. So these have growth factors to induce stem cells. Now the blood has those components to do that. But if you have blood, it condenses and goes away. It's not communicating and providing a framework for that. And so we need to have something that provides those factors. So the cool thing about regum vet, it is osteoconductive in the fact that it's a scaffold and it has osteogenic properties by getting the blood. And it says barrier, but actually it more functions as a framework. And it doesn't require suture like traditional barriers. So that's pretty cool. So this is available, can be sent to you electronically, talks about how regum vet is a framework. I have a handout on it that's can be sent to you. And it talks about how it comes in a cone or a square. I use both. So when we talk about all those differences in attachment loss, again, it depends on what we're dealing with. The problem with this picture here is we could identify the types of furcation here and how it's one stage higher, but there has to be sufficient gingiva. And this one is missing gingiva here, and there's diseased gingiva there. And so this one is not going to be appropriate. So you have to evaluate those patients. If we had gingiva that covered it more fully, then these would be ideal cases. We want to catch it sooner if possible. So this is one of those situations where it was caught sooner. I don't have a photograph of the patient, but I have this exposure of the furcation shown and how when there was caught sooner, even though the furcation was exposed and bone was gone, there was enough gingiva to cover. And so we can place regum vet in here and return it to the site. And I have a video showing that a similar use of it, similar case. It's after this one. Let's talk about this video. This is more of your traditional case you think of with bone loss around a tooth. And so we normally would have bone to this level. And so we have this pocket here to try and preserve this molar, this chewing molar. Okay, so we're going to see how we're going to place that and the steps in placement to do so. There is a distal pocket here, and we're going to measure that. And it goes really far down. It is a 9mm pocket. Is that greater than 5? Yes, it is. So can I do closed root planing or open root planing? You know it's greater than 5. Actually, 5.4 is the exact number, 5.4 and greater. It needs to be open. So we're going to make an incision and we're going to open this site. And so we're going to make an envelope flap on the alveolar margin. And then we're going to lift the periosteum. Again, I'm not holding this normally because I'm trying to let you see what I'm doing. And so it's open. I mean, if I need to make a vertical flap, I can, but this is an infrabony pocket, meaning it has bony walls. Even if I removed more flap, I still have bone covering the whole area. So I have to clean deeply
in this area, way down in here. This one's a Gracie. So I'm going to reach down and I'm going to get this edge.
You do not have to use all of these cleaning tools.
My instruments need to be smaller. I need a mini to be able to reach down far enough. But this is an ultrasonic perio tip. And so I'm reaching below the gum line and cleaning not only the root, but the bony wall as well. And now I'm going to switch to another perio tip. This is an ultrasonic curette. You can see how it has a nice water spray, and now it should keep it cool. But we have to work gently so not to damage the cementum in this pocket. You can get all the way to the base and clean the walls. You see this granulation tissue here? Right there, just kind of floating up. It's not good enough, it needs to come out. So I need to get that out. So I'm going to stop with my cleaning for a moment. And I'm going to use a hand instrument. In this case, I'm going to just use my serrated periosteal elevator. And I'm going to reach down in there and try and get the granulation tissue. Most importantly, against the distal wall. See how we're getting that granulation tissue out now? Just kind of pressed it to the inside of the mouth. This one is a Columbia, meaning it's universal. So as long as the edge is in contact, it should be pretty good. You still see I'm getting out a little granulation tissue here. My lesson to you all is we're going to suction this out and take a photograph and see that I cleaned it out well. And if I didn't, then we're going to go clean some more.
Okay, I took a photograph. It was cleaned out well. Where that photograph is, I could not tell you at the moment. And then we want to get ready to place regum. But every time I place regum without pre-placing a suture, I dislodge regum. And regum can be pushed back, but it acts sponge-like, and I like it when I place it the first time. I don't want to move it around because it always works nicely when the first time I place it and then don't touch it. So my way to save my butt every time is to pre-place a suture. So I'm getting ready to close it as if we're going to close that gingival collar, and that's what we're doing here.
We have a regum square, and I have already pre-placed my suture, getting it ready to close with a tight gingival collar. Hopefully you can see that tiny little hair suture, 5/0 Mama Mend MT. And then I am just dipping it in some saline. And then I am going to take that out and trim it so it fits in the sides. And then we're going to place it in the defect. And we're going to use our tools and press it into place. Any excess at the top where the crown is, we're going to take
right there.
away
See,
that
I'm taking that away.
And now I have filled that whole defect with regum. And so I've pre-placed that suture. Now I need to clean up this after I've closed it. I still have some more sutures to do, but I can see how that's beginning to close. I still have some stitches to close over here, but I've cleaned up the area and I have a tight gingival collar.
Now that picture looked like it didn't have gingiva, I just had mucosa. The gingiva in front of it is like 4 millimeters. The gingiva at the back was diseased and there's only like 1 millimeter of gingiva. But there is gingiva before you get to mucosa. So this guided tissue regeneration stuff is to get bone loss to come back in cases where it's already been there. The best ones are when there is bone around them, bony walls like I just showed you. And the best choice is to place a framework, specifically Regum Vet, for correct cell differentiation of types. And so this is another case where you might want to use it. This is a maxillary canine. And how many times if you see a dachshund, you just say, oh, it's going to have bone loss at the insides of the up maxillary canines. In fact, they're probably whistling already from all the air movement in there. If you have an oral nasal fistula, a lot of times your products will just go right up into the nose. And so you might not be able to use them. Regum Vet, because the cone shape is wide at the top and narrow at the base, it might be sufficient to prevent it from being sucked up in there, and can be used in some small oral nasal fistula cases. But this is one where it had not yet created an oral nasal fistula. And so we had opened it up, we had started to clean that out. And then the traditional method is placing a graft and then placing Ossiflex, and you have to suture this around it. And this is a membrane. So that graft that you place in there is expensive, and it is like sand and goes everywhere. And it's kind of an irritant if it's against the soft tissues. And the Ossiflex membrane is difficult to suture. And so this is the old method of treatment, and it is way more difficult than using Regum Vet. This is what sometimes they look like when you open them up. This is the granulation tissue. Then we have to clean that out. And if you look, I thought I'd cleaned it out. This is my lesson to you all, as I was saying before, always take a picture. And this is suction. We want to make sure that's good. But this is calculus I left behind. I thought I had cleaned it out perfectly. And yes, it's way better than the previous image, but it was not sufficient. So I had to clean that out better. And then I cleaned that out and then proceeded from there. And this is the old method, when we mixed the bone graft and placed it in there, but it's all sandy. I made it look nice, but it was all sandy. And then this is using Doxyrobe as a membrane. And it gets placed in there, but it can shift and doesn't provide that framework structure that Regum Vet places. So this is a one with Regum. This is what it looked like as we're opening it up. And then this is one where we're cleaning it out. And you can see that I did clean the walls well in this situation. Blood still went into the area, but I didn't want to dislodge that blood, because the cool thing about Regum is because once you dip it in that saline, it's going to act a little more sponge-like and help fill that space, and blood will fill that area, and that will just be give it more of those osteogenic properties. And so I used a square here, and I used half of a cone here because it was wider in this point, and it just seemed to fit the space better. Now, I also waited a little more for blood to fill that area before I closed over, but then this sealed the whole area off, and it healed 100% perfectly on this one. And so once it's in there, you just suture it closed on the sides. And so your steps for placing Regum are cleaning the site. I used to say dip, trim, press, and then close, but if you actually close, you'll dislodge it. So my recommendation is prepare to close, get it wet, trim it, press it in place, and then tie that closed. And these are tiny pictures how we're cleaning. We're releasing the flap, so it's preparing it to close. Pre-place your suture. You want to dip that in saline, trim it if needed, press it into the site. There is a little bit of Regum pressed into this site. It's really tiny, but there's a tiny Regum square there, and the suture's pre-placed. And then we closed that over, and that one healed well as well. So your important considerations are cleaning it properly. We can find the video on how to clean here. We want to make sure that the flap is tension-free and it has a tight gingival collar. You can use it on pocket depths of 4 millimeters or greater. Vertical bone loss historically has been the best. Less likely, little or no success with horizontal bone loss, but that case I showed you had sufficient gingiva, and it does work. It's just not always going to work. A lot of times people want it to do it when they don't have sufficient gingiva. So again, sufficient gingiva is a key. So let's look at another example.
So there is bone loss around the distal root, and we have a 6 to 7 millimeter pocket. But the concerning one is we have furcation exposure 2 at the mesial aspect of 208. And so we can get in there and we can get in here. And that depth is missing bone between those two roots. And there's no way we can get a tight gingival collar here without taking out this tooth, and there's already bone loss at this tooth. So we're going to sacrifice this one to be able to do open root planing and treat the furcation. This is a Gracie curette. We can see that it has one face that is sloped, not flat, when we consider in relationship to the terminal shank. And so the working edge is right here, just one working edge, and the opposite side would have this side as the working edge. But I want to use a modified pen grasp, which is, you know, like grasp like a pen or pencil, and then we're just going to modify it. And we want to get this surface in contact with the tooth root. And so this area has been opened. I'm going to reach down in there to the base of that pocket, and I am going to make sure that plaque and tartar is removed from that site, get out any granulation tissue as well. I'm going to do that on all of the roots. Go on the inside here too, because we have furcation exposure. Now let's rinse it and see how it looks. Release the tissues off of the palate, off of the bone. And so I'm gonna, normally I'd hold this instrument differently. I'm holding it so you can still see what I'm doing. I'm gonna go against the palatal bone. I'm just gonna lift it just a few millimeters so that I can expose that area to make sure we have good visualization. Now let's suction in that area. Okay, so I have released it off of the palate, and then right in here is where we have our bone loss. And then we want to use our instruments and double check that that area is clean. This is where you take a photo with your camera and you use suction when you do it. Go ahead and let's rinse this. We want to see it's right in there. Now suction or air or something. And so I see no diseased tissue in there.
So that's how we clean the area, and now we're going to place regum vet.
It looks like it's cleaned. So the first step is cleaning. We've done that. And the next step is prepare to close, because we place our everything in here. This is going to dislodge it all. So I'm going to get these tissues healthy and ready to close. First, I want to make sure we have, healthy tissues as well. This is gingiva, this is mucosa. We have a nice gingival collar around this tooth. And I can't just close it and leave a gap. I need this to come all the way around there. So I want to make sure that any mucosa is released. So I'm just going to kind of fenestrate the periosteum underneath the mucosa a little bit. And then I want to make sure this edge is fresh and healthy. So I'm going to trim that. I don't know if you saw that little bit of cruddy tissue I removed. I'm going to suction right here again. You see this cruddy tissue right there. Not very much, but it's going to be on this edentulous area. And then this has cruddy tissue on the inside aspect. And so now you can see how healthy that tissue looks, nice fresh cut edges on there. So now I'm going to prepare, we've trimmed it and ready to close, tension free. Because when I go and set this down, it pretty much wants to stay in that position. So it is tension free flap, but I might dislodge it as I'm placing those stitches. So I'm going to start by pre-placing my suture. I am pre-placing with my mono end MT taper needle 5/0. I'm pre-placing this suture in preparation to have a nice tight gingival collar. That is a key component. Now we are going to place regum in the site. Here's our graft material. This is going to be bigger than my site, but this piece fits nicely into that furcation. So I am going to open it up, and I want to dip it in saline. My cheap method for dip it in saline is place a little bit of saline in your pouch. So we're going to take our graft material, we're going to moisten it. See how it's been moistened in the saline? So that should be enough that I should be able to trim it. And I don't want to soak it because it'll be too soft. And then we're going to trim it down. And I am intentionally making this larger so I can take some away. So I'm going to cut way back here. So this site should be larger than where I need to be, but this is the part that I'm going to place into this site. So open that up. And we can see our sutures there. So I'm going to place that there. And I'm going to use my tools. And the goal is to press that into that site. So I am just going to sit here and wait while blood softens this and fills it up. So I'm just going to wait. See how it expanded a little, but it's definitely filling that entire space between those two roots. And then when I close that, it should be good. Place into the site. And now I'm going to close this. So we have a tight gingival collar. I haven't finished knotting it, though I do want to show you how I'm going to trim the edge. Okay, that should be 4 rows. 2 millimeter, 3 millimeter, 3 millimeter tags. And then I am going to grab my instrument again, and I am going to, make sure that this little bit leaked out. There we go. Now I haven't finished closing, but you can see how it has a tight gingival collar to that site.
So hopefully all those videos made sense, because you just place it and then just take away the excess. Other gelatin products don't work that well. So basically the summary is clean the site well. If it's dirty, it's going to have some failure. You can do it closed if it's a smaller pocket. Otherwise you want to open the flap to clean it well. And best for vertical bone loss, but you can use it for horizontal bone loss as well. Make sure there's gingiva replaced as the tooth collar. And so this is why I'm going to talk about a split flap, because figuring that out. So this is a situation in which we have bone loss in this manner. This tooth, periodontal disease stage 4, apical disease, this one needs to go bye-bye. This one's fine, but it's worthless. I should have taken it out too, but the owner didn't let me, but they didn't want to save as many teeth as possible. It's basically a tiny wisdom tooth, but whatever. So what happened is after I took this out, it accidentally tore right here. Well, actually, that's where I would have actually placed it. Traditionally, when you go to close this, and with an envelope flap, you bring this side and this side together, and you kind of pinch it, and you end up tying it, and you'll end up leaving a gap here. We don't want a gap there, because that gap is right above our defect. And we need to not have that. And so the only way to prevent a gap is to use a split flap with gingiva around it. And so that means we're going to take this margin here and have it go here. And we're going to take this margin here and have it go here. And then we're going to have mucosa in the center to close. And so that's, what we did. And so that collar is here, and there's a stitch and a tight gingival collar for that. This collar is here, and there's a tight gingival collar for there, and the mucosa was brought over to this area. And so in other words, we cut down to split that area, but the key is each of those teeth have a tight gingival collar. So there's a lot of graft types, there's a lot of barrier choices, but the best one is fastest and ease of use is the Regum Vet. And if you have it on hand, it'll make it easier to work with. So questions can be sent to me directly at ce@tooth.vet. Do check out the video at tooth.vet/regumvet, and I'm here to answer any questions you might have.
Thank you, Jen. It was great as always. Anyone wants to ask Jen questions? This is the time. You can turn on your cameras and ask Jen anything you want to know regarding Regum Vet, the procedure, the lecture. You have an opportunity now.
So I want to reiterate a couple of things. I did fast forward through some of those video areas. When we use Regum, it's important to make sure I'm soaking it in blood. You could soak it and make sure it regains its full elasticity ahead of time, but then I have a harder time placing it. So I just dip it so I have a slight, still very firm to be able to press against, and then so I can trim it to size, still slightly oversized, but much closer. And then it soaks and expands and fills that space. And by regaining its elasticity, it's providing that framework for all of those tissue types to communicate in that area. Other situations where I've used it are mandibular canines. It's very common to have disease around the mandibular canines and have third incisors that are lost or diseased. And we want to keep as much bone as we can. If we take out that third incisor, there's a lot of times there's bone loss between that third incisor and the canine. And we want as much bone as supporting that canine as possible. And so you can place Regum Vet in the alveolus where there's no tooth to support the regeneration of bone. Are you suggesting a max, like an alveolus or a ONF?
No, I think you have one slide that shows how it looks when extracting all or some of the incisors, and then to minimize the gum recession after the extraction, and then exposing part of the root of the canine using Regum Vet.
I didn't get it all sorted out yet. That's the problem.
Okay. Okay. I will wait. I think I have it open. I'm not sure.
If you have it, great.
Yeah, I will wait. I think I have it.
Jen, for those who still extract all teeth, can you go to the initial interest of why using Regum for the first place?
So dogs typically have 42 teeth. There's only 8 important teeth. The canines, so the maxillary canines, the mandibular canines, those are kind of like their fingers, but the mandibular canines provide 50% of the strength of each mandible. They have 2 mandibles joined by cartilage symphysis. And then the carnasals, which are this large crowned teeth in the back. The top ones are upper fourth premolars, the bottom ones are mandibular first molars. And all of those provide the chewing function. So if a dog had those 8 teeth and no others, then they would have the same structure and function as a dog that had all 42. Not exactly, but pretty close. Inevitably, the teeth they're going to be diseased are usually the smaller teeth right next to those big teeth. I have rarely found issues in which it's just those teeth. It's always next to the big teeth. And those are the ones where Regum is needed. When you need to take out a tooth, it's usually to save the others, but you need supporting bone around those others to try and preserve it and save it. And so that's why it's important to have Regum Vet to need it, because when you go to extract, this is one of those situations where you can use the alveolar bone. So on the far left of this screen here, we see the incisors already have more than 50% bone loss. Thank you for being Vanna White for me. That's exactly right. And then I was going to have a video showing that where we have the conic version placed into those sites, because you can already see the bone loss between the third incisor and the canine is significant. And we need the bone to come back around those canines. And so the regum does not show on x-ray once it's been placed, but it has a nice gingival collar around that area. And you're trying to provide stability to that site, and you're reducing it to no pocket depth. And so the regum will allow for bone to come back to that area, as opposed to other situations which allow, there's at least 10% bone loss if you don't put anything in it. I'm sorry, if you don't put a graft or regum vet in it. Just the blood alone will allow for at least 10% bone loss just during the healing process, that osteoblastic activity as bone is trying to reform. It still loses bone height. And so we can keep that structure around there and then have no pocket. Hopefully that helps with that. I could quick share this. Share. So this is doing that.
Hello, so this
Unedited.
dog, suction please, needs the proximal wedge technique. There is an under erupted canine here, and there was some thick redundant gingiva. We took it out while taking out these 2 diseased canine teeth with bone loss and mobility.
Incisor, you could tell him.
And we have an alveolar pocket here where the alveolus is. The body will fill that in with blood, but it may not come to the right height. And so we need to clean also this root of this canine to preserve it. So we're going to do some hand scaling, open root planing to clean this area out and prep the surface, and then go ahead and suction. I've already attempted to trim the margins. I don't know what's sufficient. Let's see if it's sufficient. So, the advantage of the proximal wedge technique is that the mucogingival junction line is not moved, but I've thinned this tissue, and when this lays down and then this one lays down, we'll have a nice tight gingival collar with some additional enamel, in this case, because undererupted crown that's exposed, and have a nice tight gingival collar around these teeth for better periodontal health. But bone needs to be supporting this area, and I have this big alveolus here. So I need to get prepped, ready to close. So this edge has a little pointy thing on it. I don't want that. And
Sorry, it's not edited.
Okay, it looks like it'll come together just fine. And so I need to make sure I'm cleaned out on the inside as well. Where's my scrapey thingy? Scrapey thingy, a serrated bone curette or periosteal elevator to clean any roughened areas. Okay. Yeah, go there. Okay, don't suction yet because I want that blood. So here is regum. I'm going to use a cone to support alveolar bone level height to be at the appropriate level. So I open my packet. I don't need to trim this one. I'm going to use the whole cone, but I am going to start it by, I just dunked it briefly in water. I don't know if you saw that. And I am going to then place it into the alveolus. And I am going to just sit there and let it expand, and I'm going to wait. And I am going to press against it so that it fills the whole area. So just wait, wait, wait. Can you suction that? So there it is at the level of alveolar bone. Can you see that? I think we can. And so this regum cone is filled with blood. And because it's kind of so spongy, it's going to stay right at this level of alveolar bone where we want it, down here. And then we're going to close it. So then I need to get suture in here and close this up.
So that was an unedited 3.5-minute video. So how long does it really take to place regum? Not very long. How easy is that? Not difficult. And so you just have to make sure the area is cleaned, and you wait for it to soak with blood. and you close that area up. And so it's pretty easy to do, and it's going to bring back that supporting bone around those 8 important teeth. So hopefully that helped as well.
Thank you, everyone.
Thanks for joining me.
Thank you.
Thank you.
Thanks, Jen.
Thank you very much.
Thank you very much, Jen.
Bye.